like hypertension or like cholesterol meds, stuff like that. I'm more than happy to answer some of those as well. If I don't know the answer, I will let you know as well. So yeah, with that, we can definitely open it up, and who'd ever like to go first?
You all are welcome to either unmute yourselves, put it in the chat, and I can read it, however you'd like to ask.
Anyone?
Hi. So my name is Mandy, and the chat was disabled for me, but for some reason. But what I was curious about is ADHD medications
Mhm.
because I have a child on ADHD medication.
Sure.
As far as any like addiction potential, and also any like overall safety concerns. That's one,
Sure.
and then also about risperidol.
Sure.
Thank you.
Yeah. So I'll start out with some of the more commonly prescribed kind of first line meds, which we typically use for more like moderate to severe ADHD, which would be like our stimulant medications. Our stimulant medications have two major groups to them. So you have the methylphenidate side, and that's like Ritalin, Concerta, moving into some of the newer stuff like dexmethylphenidate, which is like Focalin and Focalin XR. And then you also have your amphetamine side, which would be like Adderall, would be probably the most commonly used of those nowadays. Adderall XR, Vyvanse as well would be on that side. So those are controlled substances, and they are C2 or like Schedule 2 medications. So there is some addiction and abuse potential to those medications. However, people with ADHD are at higher risk of developing substance abuse problems down the line uh, when not properly managed. And using our stimulant medications to help treat that actually brings that down to the normal level. So when appropriately managed ADHD, you do see it come down to normal. So the meds themselves do have abuse potential for sure, and they are related to drugs of abuse. So obviously the amphetamine side is you know, related to methamphetamine. And you can technically get a prescription for methamphetamine for treatment of ADHD as well. Now, that's not very commonly done nowadays, but it is something that can be done. So the difference is that we're using very small quantities of like amphetamines and methylphenidate compared to what people use to get high for a specific medical purpose as well. Uh, because people with ADHD, the balance of chemicals in their brain is different from those of us that don't have ADHD. So what we think is the main problem in ADHD, or at least one of the problems, given the meds that we use to help correct it, is that you don't have enough dopamine in like the very front part of your brain, like the prefrontal cortex and the frontal cortex, which is involved with like attention and executive function, which is like your ability to organize and keep a schedule, things like that. So what our stimulant medications do is they, on the methylphenidate side, act as potent, what we call reuptake inhibitors, which means that they boost the amount of dopamine that's available in the space between the cells. Because kind of the weird thing about neurotransmitters is that you don't actually want them inside the cells to do their job. They are actually supposed to be just outside the cell in the very space between them called the synapse. So your body likes to recycle. And one of the things it does is it kind of vacuums back those neurotransmitters back into cells. So what things like methylphenidate do is they block that and increase how much dopamine is in the synapse. Amphetamines do that as well, but they also cause your cells to release more dopamine as well. So they're a little bit like a dual action as opposed to a singular action. But in practice, it doesn't really make too much of a difference in terms of their efficacy when you look at overall rates. Now, most people do end up responding better to either the methylphenidate side or the amphetamine side. It just kind of varies patient to patient. Uh, and then, especially with our kind of more modern molecules, which would be things like dexmethylphenidate or Vyvanse. which is lisdexamphetamine. So they're just like more specific, more refined versions that are more specific to the specific receptors that we want to be hitting. So they tend to be pretty well tolerated. We start out low and then work our way up over time. Pretty much the universal thing that you see, there are a couple of like kind of universal side effects that you do see with our stimulant medications. So those would be appetite suppression, would be kind of the number one thing that we want to look out for in terms of, in a developing, adolescent or child. Now, it doesn't actually really cause growth suppression. There hasn't really been a significant difference found, and there certainly are medications, especially certain anti-inflammatory molecules called corticosteroids. That's like prednisone or methylprednisone, stuff like that, which has been found to cause growth suppression. There hasn't really been. The information we have is if it occurs with with a stimulant, it's very minor. So you might be like looking at an inch shorter than maybe they would have otherwise been. But again, that's not even well established. Really, there's really no significant difference that's been established. But we do, of course, want to make sure that the patient has adequate appetite and they are able to, eat for nutrition and a developing body. So a little bit of appetite suppression is like kind of acceptable, but if they then start getting like no appetite whatsoever or start losing weight or something like that, then we would definitely want to look into trying a different medication or adjusting the dose as well, because these are things where you start out low, kind of work your way up over time, give the body time to adjust. The other thing that we look out for that's pretty ubiquitous is, not surprisingly, insomnia, so difficulty falling or staying asleep. And really that's what we do with the different release formulations. So there are a ton of different products that are available with different durations of action. So you have ones that are like immediate release that only last like a couple of hours, where you might have to take those a couple times a day. There are ones that are geared to last like 8 hours a day, so to get someone through school or work. There are ones that are 12 hours, so getting through school or work plus like a little bit of extra time in order to do homework and stuff. There's ones that are even like a little bit longer than that, because we want to get them through the day, through the amount of work that they have additionally, plus then wear off to allow them to get to sleep as well. So there's like a lot of customization and a lot of variety that allows us to kind of tune those different regimens to each individual patient. Now, of course, there's some other risks to it. So one thing is that every single thing with antidepressant activity, and that includes like amphetamines and methylphenidate, they do technically have antidepressant activity. So every single one of those things are labeled with an increased risk of suicidal thinking in adolescents and young adults, which of course worries everyone because it sounds ass backwards as to why we would use them. So that warning is based on one of the worst studies that has ever been done, in my opinion, in terms of actually looking or controlling for things that should have been controlled for. And it actually is related to a medication that is not even in the same realm as our stimulants are. So that would be something called Paxil or paroxetine. What they did in the study that led to that warning was they asked people who had, one, either taken an antidepressant before, in this case it was paroxetine, or two, had never taken an antidepressant before in their entire lives. And then what they did was they asked people, have you ever had suicidal thinking? And then did not bother to ask when that was. So that study showed people who had taken an antidepressant were more likely to have had suicidal thoughts at any point in their entire lives than people who had never taken an antidepressant. Yeah. People with high blood pressure are more likely to have had, been on blood pressure medications too. And then all the information that we've had, or I shouldn't say all, but the vast majority of studies that have come out since have shown that warning is kind of bunk and not really true. And I mean, there are definitely, that's not to say that people have not started an antidepressant and then not gotten worse. It's just that medication wasn't working for them. Either it wasn't dosed appropriately or it was just a bad fit for them. It wasn't a direct action of the medication. So I'm not saying people have never experienced that or that I don't believe them. It's just there are other reasons as to why that could be the case. So definitely if, your child experiences that afterwards, definitely tell your doctor, absolutely believe you. This just could be some other thing going on. And that'd be more common like you'd see in like major depressive disorder or bipolar disorder if that were to happen in someone that has ADHD that doesn't have those symptoms of the disease state itself, then absolutely let your doctor know. But that warning just freaks everyone out for sure. I mean, and like it makes sense like as to why that warning freaks people out. Then you like kind of dig in and like look at what got that warning. Then there's some other things. So like technically you're increasing electrical activity in the brain with a stimulant medication. So it technically makes it a little bit easier to have a seizure. Now, if they've never had a seizure before, the risk of it actually causing a seizure is like absolutely minuscule. You have this like maximum amount of electricity you can have at your brain like at any given time. It's called your seizure threshold. Most people run like really, really, really far below that. So like if you increase the like a little bit, you're still nowhere near. Some of our other medications do the opposite thing where they bring the ceiling down. That technically makes it a little bit easier. But if they don't have any history of epilepsy or seizures of any kind, it's not likely to see that occur. But like in general, our stimulant medications do have a good established safety record, are generally well tolerated when you adjust for dose. But we do have some non-stimulant options as well that can be used either alone or can also be used in combination with stimulant medications. So some of those non-stimulant things would be, one would be something called guanfacine or Tenex or Tunit or Intuniv when it's the extended release formulation of that. So rather than working on dopamine, those work by helping to regulate the adrenaline system, because not only does dopamine play a role, adrenaline also seems to play a role in ADHD as well. So it helps regulate that. Clonidine is a close relative of guanfacine, so they're in the same class. The other ones would be some of our Strattera or atomoxetine or Qelbree would be other non-stimulant medications that are sometimes used to help manage ADHD in like more mild to moderate cases. And then sometimes even certain antidepressants are sometimes used in like mild to moderate cases as well. Specifically one called Wellbutrin is probably the most commonly used for that, although sometimes like Effexor, which is venlafaxine, or Cymbalta, which is duloxetine, are sometimes used for that, but typically you see Wellbutrin used. So there are like stimulant, non-stimulant options. There are like wide varieties of them, and yeah, generally we are able to tune a regimen in order to help maximize benefit while minimizing some of those side effects that I went through. All right, great. Oops.
Thank you. That was very, very, very helpful.
Oh, glad to hear.
Well, I'll ask a question because I can't get into the chat either. It won't let me put anything into the chat.
No, that's okay. No
And that's
worries.
okay. So I actually have two different questions,
Mhm.
and you can answer one of them or both of them.
Okay.
One is, what's the latest thinking on medication for OCD disorder?
Mhm.
And the other is, can you talk a little bit about the newer medications related to depression, treatment of depression?
Sure. Yeah, I'll start with OCD in terms of, unfortunately, no real new developments that I'm aware of right now. I mean, that's not to say that we don't have anything that treats it. It's just going to typically be our antidepressant medications, especially those that are really focused on serotonin. So a lot of times the first steps that we see are going to be like your SSRIs. So that's like Prozac, Zoloft, Lexapro, Celexa, Sometimes in OCD, there is an additional one that has a little bit of a niche, which is fluvoxamine or Luvox. It's not quite as commonly used as the other ones, but is something that does have like a solid reputation. It's maybe a little bit more sedating than some of the other SSRIs, with the exception of Paxil, just because the Paxil is like the most sedating of the SSRIs, at least. So can definitely make people feel tired, but otherwise is a very, very similar safety profile to our other SSRIs. With that too, you can look at like SNRIs, so Effexor, Cymbalta, Pristiq. So that'd be like venlafaxine, duloxetine, and desvenlafaxine. And although I'm like using the brand names and generic names interchangeably, because sometimes people are more familiar with one versus the other, I have no like disclosures of any type. No one's paid me off. I paid off my student loans myself. Then like sometimes with OCD, we do dip into an older category of medications as well, called the TCAs, or tricyclic antidepressants. Now, probably the gold standard of treatment for OCD is something called clomipramine. Now, we don't use it first line, even though we believe it's the thing that works best, just because it also has a significantly worse side effect profile than the other ones. You see a lot more sedation with that, like a lot of anticholinergic activities, that stuff like dry mouth, dry eyes, constipation. But the major thing is that TCAs aren't particularly safe in overdose. Now, certainly other antidepressants obviously can be fatal if enough is taken, but TCAs are just much more toxic in overdose than our other antidepressant classes. So obviously, if someone like ODs on like Prozac or Zoloft or something like that, they're going to need medical intervention. But generally, you like intubate and sedate them and like let their liver chew through it. And generally, if they do get that medical help, then they've got a really good chance of pulling through. Whereas with our older like TCAs, they can give like a cardiac arrhythmia that's just fatal, and there's not really an antidote or anything for it. So unfortunately, at least from like a medication standpoint, there's nothing super new. Now, of course, there is a lot of kind of talk about psychedelics and stuff for certain mental health conditions, but none of that's like really approved yet. And that's not to say that it won't be in the future, or that there aren't some studies that support it. It's just nothing that I can really comment on in terms of recommending something, because there's nothing like approved, and still technically like your psilocybin or LSD or mescaline or whatever other thing is still technically an illegal substance. So I can't really ever recommend taking an illegal substance for my license purposes, for sure, but also just because we don't have the data to support it, at least yet. Now, if those studies do come out, definitely there may be something there. I'll say there may be something there, but we don't have enough high quality studies yet. So for antidepressant stuff, there is actually kind of more news with regard to that. So kind of the biggest thing that has come out within the last like couple years, it's been a couple years now, but it's still not super widespread yet, is something called S-ketamine, or Spravato. So ketamine itself, which yes is like, a lot of people think of it as like a horse tranquilizer, but it is something that is used in humans as well, for especially like procedural sedation. And I'm sorry if you can hear cats running around in the background. So ketamine has long been known to have rapid antidepressant effect, but it's also super sedating. It's got like abuse potential to it. There's like only limited places you can give it. So basically, when people were getting like experimental ketamine therapy, it was in like what we call the PACU, which is like the post anesthesia care unit, like when people come out of surgery. they'd be administering it there. And then there were some problems because some data suggested that there were kind of diminishing returns with it too. So like initial doses, you might get antidepressant effect for like about a month or so, and then that kind of came down until it only lasted for about a week or so, give or take. So Spravato, or S-ketamine, is a more focused version of ketamine. So I won't get like too into the weeds in terms of organic chemistry, because you have to talk about centers of asymmetry, which we call chiral centers, and you've got like left and right-handed conformers and like all this stuff. But basically, there are usually two different what we call enantiomers, which are two different versions, and they're kind of like mirror images of one another. And I'm using my hands because you have like a right-handed version and a left-handed version, basically, depending on how you like measure the different chirality and the different asymmetry, which don't ask me to do because it's been a long time since I've taken OChem. But basically, S-ketamine is the specific left-handed conformer of that. And the weird thing is that sometimes with these different mirror images of one another, sometimes one form of it fits better with some receptors versus the other one. So sometimes, even though it's technically the same chemical structure, because it is the mirror image, sometimes it fits better with some receptors versus other receptors. And this is actually what you see with like some other medications. So like probably one of the more famous ones, at least in terms of psych, would be citalopram, which is Celexa. Then you have escitalopram, which is Lexapro. So this isn't like a brand new thing that hasn't ever happened before. This has been a thing that we've known about with certain medications for a good 10, 20, maybe even longer than that years. So S-ketamine has a couple advantages over ketamine itself. One is that you don't have to get an IV infusion of it. Weirdly enough, the way that you have it administered is through nasal inhaler, which is a little bit wonky, but definitely better than getting it intravenously. And then also, you don't have to have it be given in a PACU. Now, you can't take it at home, but there are certain centers where you can get it administered. And basically, you just kind of go in a room and get the nasal spray administered, and then you kind of chill out for a couple hours. Generally, about 2 or 3 hours is typically what is recommended. I think 3 is generally the recommended duration of time. And most people will either like take a nap, or they'll bring a book, or some other activity. And then they're just monitored to make sure they don't have like over sedation or anything like that. And then they can go home afterwards. Now, you can't drive yourself, so you do need a ride. But it is something that has rapid antidepressant effect. So the biggest annoyance for everyone involved, including the people that treat it, and I'm a patient as well as someone that is involved in treatment. But yeah, waiting 4 to 6 weeks when you feel awful and you feel like everything is terrible, and in the most severe cases you're potentially like suicidal. Waiting 4 to 6 weeks for something to kick in can feel like a really, 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 really long period of time when you're that miserable. So S-ketamine, you can actually see results as early as like literally the first dose. Now, sometimes that's more like after 2 or 3 doses. Initially, you're starting out usually like twice a week. Eventually, sometimes people in like a maintenance phase go to once a week dosing with it. There are different levels of dosing as well, so it can be adjusted person to person. And it is a new, like in terms of like something being approved for depression, is a new antidepressant class. So there's nothing really that works like S-ketamine. I mean, other than like ketamine, but that's not approved. And rather than working on like serotonin or norepinephrine or both or dopamine, it actually works on glutamate. So glutamate is a neurotransmitter that a lot of people don't think of and kind of gets overlooked even in the medical community, even though it is quite literally the the main excitatory neurotransmitter in your brain. So actually the most neurons in your brain that are get like stimulated by something, it's actually by glutamate. So it's actually one of the most common neurotransmitters in the brain. And what we think happens is if you overstimulate certain glutamate receptors, that can have negative consequences on mental health. And that includes stuff like depression, bipolar. I mean, there's even information with other even more like neurological conditions, like dementia, overstimulation of specifically the NMDA receptor, which is a type of glutamate receptor, has been associated with like neuron death. And what ketamine and S-ketamine are, they're potent inhibitors of that NMDA receptor. So they block that overstimulation of glutamate at that specific receptor. But because it works like nothing else, it's something that can be added on to other antidepressant therapy as well.
Yeah.
So it's something that you don't have to like completely abandon any other treatment for. It is something that can be used to like what we call augment other therapy. So it has an indication for treatment-resistant depression, which is if you failed 2 or more antidepressant trials, then it would be indicated potentially. And then also it is the first thing that has ever been indicated for acute suicidal ideation. So when someone comes in and they are in like a horrible spot, they are thinking of hurting themselves, ketamine or S-ketamine, Spravato, is actually indicated for that. And it's the first thing that has ever been indicated for that. So that's kind of like the newest cutting edge thing that's available. And we've had a couple patients on it that it seems to have they've done really well with it. I mean, other people would be more familiar with it just because in the hospital, it's not on formulary, at least not yet. But it is definitely something that we are looking into for sure. And even looking into potentially opening like there are some talks about potentially looking at opening like a Spravato or S-ketamine clinic as well in our health system. So, and there are other health systems that have been doing that. So I know that there's a couple different centers around Rockford that already do it. So it's not like you can't get it around here. You definitely can. I believe there's like 4 different centers, if I remember correctly, around Rockford that do it already. But yeah, so far it's had really good success.
I have a question. Can you hear me?
Yes.
Okay. My wife has dementia with psychosis and major depression. So
Sure.
my question is, she's prescribed multiple psychiatric drugs. And I'm wondering who coordinates all the medications she's taking, the psychiatric, all the other things. And we have multiple providers, which complicates it more. And I'm told by the prime care that it used to be you'd stop the other guy in the hall and say, how's she doing? And he'd say, let's try this med. He says that doesn't work anymore because the doctors are isolated from each other.
Gotcha.
And how do we follow up on interactions, the possibility of interactions?
Yeah. So in terms of like direct medication to medication interactions, one of the best things you can do is maintain like a single pharmacy. I don't know, like if you get it always like from the same place, and of course, like a lot of places like want to go to mail order and stuff now too, which is not my favorite. But at least like when using like a singular pharmacy, they can run different interaction checks if they know everything that a patient's on. In terms of getting the physicians to kind of communicate with one another, that can absolutely be kind of a frustrating thing. And even within a single health system, sometimes that's a little difficult to do. And then if they're coming from different places, that can, even add to that complexity a little bit more, for sure. Now, are they from the same health system, or are they from like a couple different health systems?
They're in the same health system, but they're not geographically close to each other.
Okay. if they're in the same health system, they should technically have access generally to other like notes. So like just for example, like and I'm not going to ask like exactly what clinic it's at or anything like that. But for example, like at like within UW Health, even though we've got different facilities, we all use the same electronic health record. So if someone sees someone in like Madison, even though like I'm in Rockford, I have access to that. Like I can actually still read that note. And that's usually how it goes nowadays is if you're like within a single health system, generally they're going to have like a unified electronic health record, like the one we use at UW Health is something called Epic. Technically it's HealthLink, which is a specific version of Epic. But there is that ability to read different notes. And actually, even sometimes you can read notes outside of your system too if they use the same electronic health record. So
Yeah, we are on Epic, so that
gotcha.
probably, yeah.
Yeah, so really they should be able to. Now, is it like neurology? Like I'm guessing like primary care is involved, but are there like specific people that are ordering different things for like the same condition? Like are they all ordering different things for
No,
dementia
different,
or
different conditions.
different conditions? Okay.
Yeah.
Yeah. So if it's for different conditions, the biggest thing I would say is like consolidating, and you may already be doing this, but consolidating all prescriptions through like a single pharmacy. And I mean, that can be like all through a single Walgreens or a single CVS or a single, like wherever it
It's all
is.
through Optum, the mail order.
Gotcha.
Yeah.
Then they should be screening. So for example, when like it's been a while, but when you're getting even like a refill of a medication in a pharmacy, it should be running an interaction check like every single time, like the software itself does. So for example, like when I was at the hospital earlier verifying different medications, it's running a drug interaction check every single time on every single medication. And sometimes interactions don't mean you can't use medications together. So a lot of time, because there are different like severities. So sometimes this is just a thing where you just have to be a little bit more conservative with dosing, like start out lower or only go up to a certain maximum dose. Only in like really pretty rare cases do you actually have like do not ever use these together. Those happen for sure, but they're not typically what you see when you see an interaction. Usually it's just warning you, okay, if you're going to use these two together, just be careful. Here's what you should do to help manage like that risk, to help minimize risk. So yeah, a lot of times, even if interactions do occur, you can still use different medications together and you just have to be a bit more careful with them.
Yeah, sometimes it looks like the side effects are compounding with the
Sure.
different medications.
Yeah, yeah, and that's something that is typically checked in an interaction checker. Although a lot of times that will just be like additive sedation. So just be careful, like when driving or something like that would typically be something. But yeah, I mean, definitely if you have different medications that can all cause the same sort of side effect and then you're adding them together, they can definitely compound on one another for sure. And it's always like a good thing to talk with the different doctors about too. So if you are getting some concerns or you are noticing like, hey, my wife is having this problem and all these different meds say they can cause that problem, should we be like cutting back or eliminating some of those? So, I mean, it's definitely great to follow those sorts of things and definitely talk with your providers about that too if you do have concerns.
The kind of second part of this question
Sure.
is we seem to be running through a cornucopia of medication for the dementia.
Sure.
There is no clear treatment for it. Is that what's going on?
Kind of. So there are a couple different medications that are approved for dementia. And it is something that is actually in flux right now. So we're actually in sort of an interesting, I'm trying to think of a way to phrase this. So some of our older historic meds that we have used to treat dementia, specifically Alzheimer's disease, which would be things like Aricept or Namenda. So what those do is they don't really slow the progression. What they do is they kind of cause this initial bump in function, which is then kind of maintained. So you kind of go down at the same slope, but it's not really slowed. It's kind of like this weird, I know it's like hard, I might not be explaining it super well, but like you get this increase in function, but then you kind of keep going down at the same rate.
Yeah.
Um,
So that's why they keep changing medications, because it kind of wears off.
Sometimes. Now they're looking at a class of monoclonal antibodies, which are actually a type of immune system medication, specifically like inflammatory sort of stuff, that does indicate that it might slow the actual progression of Alzheimer's disease. So there are a couple of those that have come out just like within the last year or two, but they are still kind of so they are like approved, but they're still going through what we call like a phase 4 study, which is like after it has come out. Now, like the problem with those is that even if they were to slow progression, like they don't reverse things. So they don't really bring back function that's already been lost. They slow the progression of it.
Right.
So those are sort of the medications that are now kind of being looked at, although they do have some pretty heavy warnings on them as well. One of them in particular was quite controversial because it was found to have like an increased risk of aneurysms to it. I can't quite remember the names of the medications because I haven't seen any of them yet in like practice. There was one that came out after that didn't have that same problem. So I'm not saying like all those medications cause that. It's just one in particular. And I don't want to besmirch any of them by throwing out the wrong name of them. But if you look at like, if you just type in to like Google or something, like new Alzheimer med, like, and you can just do like MAB, which stands for like monoclonal antibody. That would probably be enough to pull up some of those new medications that have been approved for it.
The other thing is she's 86 years old, and a lot of these medications say not for elderly people.
Yeah. Yeah. So especially our second generation antipsychotics. So it sounded like she may be on those, at least, or one of them or something. So technically all of those are labeled with a warning for all cause mortality in dementia patients. So technically, and that's not like a specific cause of death or anything like that. It was just noted that dementia patients that were put on them did have increased risk of death. So all cause mortality. Now, that doesn't necessarily mean you can't use them. Is that you have to be very careful when using them and make sure that you have a reason to give them. So especially if like there are concerns with, potentially like harm to themselves or others, or like if she's having like delusions, hallucinations, paranoia, stuff like that. You just want to make sure that you have a good reason to give them, as opposed to, just putting them on without thought. So there is that warning for it for sure. And then of course, like
part of it is you pick your poison.
Sometimes, yeah. It's always like everything in medicine is like a risk versus benefit sort of thing. So it's the type of thing where you do want to be very careful when initiating that. But I mean, if there is a reason to use it, then sometimes you kind of got to use them. So it is sometimes a little bit of a damned if you do, damned if you don't sort of thing. So sometimes you do get into those situations. But sometimes like those things too are used to treat like depression as well. So like I know you mentioned your wife has depression as well. So
Yeah.
sometimes when people have like treatment resistant depression, sometimes they are put on like a second gen antipsychotic in addition to an antidepressant to kind of get it to work better. Because second gen antipsychotics like Abilify, Geodon, Latuda, Risperdal, Invega, Zyprexa, Clozaril, Rexulti, Fanapt, Vraylar. There's like a million of them
A
nowadays.
lot of them she's taken
Yeah,
already.
yeah, those have antidepressant effect to them too. So even if she didn't necessarily have like, psychotic symptoms, sometimes there might even be a reason to use that too. So it's like hard to say, of course, without like seeing a file or anything like that. And I'm not saying you should send me the file. I'm not saying that. I'm just saying, sometimes it is like a risk versus benefit thing where even you do have that warning, but sometimes it's still kind of worth the risk. But what we always want to do is, make sure that we have what's called like informed consent, where you are educated about that. You are informed of like the risks versus benefits of treatment. Because yeah, sometimes there are definitely risks to treatment too.
If I can insert a personal note, I served a church in Rockton for several years. That's
Gotcha.
somewhere in your neighborhood, right?
Yeah, yeah, yeah.
One of the medications that she was on for a while was Nuplacid. Are you familiar with that one?
Well,
It was apparently limited to Parkinson's with psychosis.
Okay.
They were
Yeah.
able to get an exception,
Gotcha.
even though she didn't have the Parkinson's.
Yeah, I think that's like pimavanserin, if I remember the generic name of that one correctly. Yeah, so that one is a little bit of a unique second gen antipsychotic where it does have that indication because in Parkinson's disease, what you have is like the death of dopamine neurons in the brain. And a lot of our antipsychotics block dopamine. So if people have Parkinson's disease, that can actually make those symptoms worse. Whereas pimavanserin is one that is the least likely to do that. It's like the most focused towards not causing those sorts of symptoms. So yeah, actually I did not long ago, by coincidence, actually kind of look into a prior auth for a prior authorization for a patient that had Parkinson's and also some psychosis. So yeah, that one, I mean, it's going to be similar in terms of its side effect profile to the other second gen antipsychotics. But yeah, that's just a little bit of more focused molecule.
Thank you.
Yeah, no problem.
There's a question in the chat. What do you
Sure.
think about, I'm gonna butcher that name, Cobenfy?
Oh, here, let me open it. Oh, Cobenfy. Yeah, so that is our new antipsychotic. So to tell you the truth, that's a great question. I don't have too many thoughts about it yet, just because I haven't had experience with it yet, but it is something that is really exciting. So to have a new mechanism, I mean, it's a little bit like debatable if it's super new in terms of its mechanism, but to tell you, like the thing that works closest to Cobenfy is something called Clozaril or clozapine. Now, some of you might be familiar with that as being like the most hardcore antipsychotic there is. It is something that is typically only used in treatment-resistant schizophrenia. And the big scary thing about it is that it can cause something called agranulocytosis, which is like wiping out your white blood cells. Now, we've known for a long time that Clozaril doesn't really work like the other second gen antipsychotics. So Generally, for our second-gen antipsychotics, they work by regulating two different chemicals in your brain by blocking very specific types of receptors. So one is dopamine, and specifically the D2 receptor. And then the other one is serotonin at specifically the 5-HT2A receptor. So overstimulation of those two receptors has been associated with in dopamine, with the D2 receptor specifically, that's like with delusions, hallucinations. And then we also know that the 5-HT2A is actually one of the active sites of LSD as well. So by blocking those two receptors, that's typically how our second generation antipsychotics work. Clozapine, however, is a little bit muddier than that, and it's been long thought that it had some degree of what we call like muscarinic activity. So muscarine is a subtype of, well, muscarine is like the thing that stimulates these subtypes. So they're called muscarinic receptors. You might have heard of nicotinic receptors, which is where nicotine works. So these are the other version of acetylcholine receptors called muscarinic receptors. And clozapine seems to have used it or had its effect, at least in part, through some cholinergic action at those muscarinic receptors. So what Cobenfy does is it basically goes all in on that. And it's exciting because even if, say, it doesn't necessarily completely drastically improve treatment, it still provides us with a really interesting and novel target that you can use potentially in combination with other antipsychotics. So because it works differently, you might be able to kind of attack psychosis from a couple different angles. Or if people have failed a whole bunch of different medications that all kind of work similarly, well, now you have this new option that works in a different way that might be more beneficial towards them. So I would say cautiously optimistic would be the closest I have to thoughts about it, having not had specific experience with it yet in terms of having like a patient on it. But it is something that like anytime you get something new, even if it's in the same class, can still be a good thing because based on a person's genetics, that can change the shape of different receptors in their brain and you can think of them like literally like puzzle pieces where there's a literal physical fit to them, where a person's genes can change the shape of those receptors a little bit, which can mean one medication works better for one person versus another. So even if you do have a medication in the same class come out, that's still maybe going to be a really good medication for a lot of people that maybe didn't find success on other medications. And then to take that like a step further and now have a medication with a pretty novel, a relatively new mechanism of action, that's pretty exciting too. So yeah, I would say cautiously optimistic. I mean, hopefully it like revolutionizes everything and is like the greatest medication in the world. We can all hope. But yeah, at the very least, I think it's going to be a solid choice of medication for people that may have failed quite a lot of other antipsychotics, or maybe they've responded pretty decently to their current therapy, but it could be going better. In which case, because it works differently, it could be a very good augmenting agent or add-on therapy as well.
Do you work with a lot of people that have done the gene site testing?
So yes and no. So for genetic testing, there is utility to it, but it only tells us kind of part of the picture. So it is something that, especially if someone has failed a couple different medications, can definitely be useful. So current gene testing, at least when it comes to mental health medications, what they do is they can tell you how your body processes different medications. So you have a couple different like really big, what we call enzyme systems in your body. which a lot of times they're focused towards the liver, but there are some other ones that aren't specific to the liver. But based on a person's genes, at a whole bunch of different, I'll just go through the whole spiel. So basically, the biggest enzyme system you have in your body, at least when it comes to medications, is something called the cytochrome P450 system. I don't know why it's called that, but that's just what it's called, is the cytochrome P450 system. And we tend to abbreviate that like CYP, or CYP is typically how we pronounce that. And then you've got a bunch of different subtypes of that with all different alphanumeric names. So you've got like CYP1A2, 2D6, 2C9, 2C19, 3A4. Like there are a whole plethora of them. Like there are dozens, hundreds, I don't even know how many there are. There are a lot. But we know that certain ones are really, really important for how your body processes different medications. And your body, it's not like, oh, you're just going to be an ultra rapid metabolizer, or if you've got like quote unquote like fast metabolism, that doesn't mean that every single one of those you're actually like a really fast metabolizer. At each individual one of those, so at like 3A4 or 2C9 or 1A2, like each individual one of those, you might be a slow metabolizer, a regular metabolizer, a rapid metabolizer, or an ultra rapid metabolizer. At each individual one of those, and different medications go through different ones. So for example, like Abilify and Seroquel, they go through CYP3A4. So if you are like an ultra rapid metabolizer at CYP3A4, you might be chewing through those medications so fast that you like may as well not be taking them. So if that's the case, then they're not going to work for you really. Conversely, like let's say you're a very slow metabolizer at 3A4, then you might be more likely to have side effects from those medications. So you can still use them, but you would want to start out really low and then like work your way up slowly. So it can definitely direct like you towards medications that are more likely to work, or ones that are like, don't use them because you may as well not be taking them. And it's not just those CYP enzymes. There's also like kind of circulating enzymes in your bloodstream called like P-glycoproteins or PGPs. So it's looking at a whole bunch of those different ones, and can really give you a good kind of baseline of what may or may not be a good choice for a medication. But it's not the entire story, because in addition to that, variations in genetics can also, as I kind of mentioned before, alter the shape of the different receptors that medications actually have to bind to at the actual site of action. So right now we're really good at looking at how your body processes the medication, but we're not so great at how those medications fit in with different receptor like variations that people might have called alleles. So each individual like version of a gene, like it's one gene, but you might have different versions of it, which affect all different variances of stuff. But each individual thing's called an allele. So we're not there yet. I mean, that's something they're actively working on, is looking at those different receptor shapes or subtypes or alleles and looking at which medications fit best with those, but not quite there yet. Now, hopefully in the not too distant future, that is something that's going to be more available, and will help take some of the kind of trial and error out of medication selection. So I would say, yes, it is definitely something that is useful, and can have a good utility, but it's not quite like the end all be all of telling us exactly like what medication is exactly going to work best for each individual patient, at least not yet. Now, even like when that does come out, there's probably going to be another thing that affects medication too, but like each time, like you're getting closer and closer and closer. So yeah, if people have had like failed a couple different medications, yeah, it's definitely something to look into. It usually takes a couple of weeks to get the results back. I think insurances have been getting better about covering as well. So when they first came out, like no one was covering them, so people were paying like $500, $1,000, something like that. Insurances, I believe, are now quite a bit better. So I think most people end up paying in the area of about $100 or so, which again is not nothing. And for a lot of people, that's a pretty significant charge. But I mean, some insurance companies might be covering it more. That they may be getting even better than the last time I kind of checked, which it's been like a little bit of time since I've like took the lead on getting that, because it is typically more of an outpatient thing, just because again, it does take a few weeks to get back. And I'm on an inpatient psych unit where we're in acute care, where the average length of stay is like 5 to 7 days. But yeah, it is something that does have utility for sure.
Thank you.
Mhm.
We have time for one more question from anyone?
Sure.
Don't be shy. The chat works now, by the way, also.
Well, I'll go back to my question about OCD. I'm a PhD social worker working in an outpatient setting, and I have a client who has pretty severe OCD, and the primary care docs are using Prozac in this case, but like at 40 milligrams. And when I read like dosage recommendations, it looks like that's nowhere near what needs to happen. And of course, I'm a social worker. I can't tell the doctor how to prescribe things. And
Yeah. So, oh no, go ahead.
go ahead. So I don't quite know. I mean, what I did do was send him an article, but
yeah, and with especially anxiety conditions or like OCD, typically you are looking at like pretty much maybe not the highest dose, but maybe like one step down from there. So yeah, like I usually quote like 75 to 100% of the maximum dose
yeah,
for like OCD especially, but like also anxiety or kind of not on the anxiety spectrum anymore, but kind of related disorders in some nebulous form. So that might be like PTSD or like generalized anxiety disorder or panic disorder. They just
yeah,
are typically more stubborn to treat than like just major depressive disorder.
yeah,
And I say that as someone with MDD, it's kind of basic by comparison.
yeah.
So with Prozac, you'd usually be looking at like 60 to 80 for that. So it can be a little bit tricky. Sometimes I turn to passive aggression. Like, isn't it usually like, don't they usually use, like kind of the higher doses and usually like 60 to 80? Like, maybe it's working well for this, but what if we just like tried a higher dose? It's not any worse tolerated at
Yeah, but you can do that because you're the
yeah,
pharmacist. I'm the social worker, but
yeah.
I can't say things like one time one of my clients was being her bowel. She was being treated for her bowel and being fed through a tube, and
Mhm.
they had her on a huge anticholinergic drug. And so I was like,
Mm.
"How'd you decide to use this anticholinergic drug?"
Yeah,
And then they changed. But anyways, and I would refer to a psychiatrist. I just don't have access to good psychiatric treatment where I
yeah,
am.
yeah. Um, yeah, that can definitely be tricky, but I mean, it's great that you're advocating for your patient and trying for sure. Maybe just keep hammering on them, and sometimes you can annoy them into submission.
Yeah, that's a good point, and I appreciate it. And I've been doing this job. One of my supervisees is on this link here, but I've been doing this job for many, many years, and so I kind of know things that I'm not supposed to know to kind of advocate for. But this is the worst case of OCD I've ever seen in a young
Sure.
person. I mean, I don't know how
Yeah.
she survives.
Yeah. Yeah. So yeah, typically for OCD, like you're usually pushing it towards just about the max, if not the
Okay.
max.
Well, I'll keep doing it then.
Sure.
Thank
Okay.
you.
Yeah, I see. One more question in the chat. I see from Amanda. So, so can Concerta or similar stimulants increase aggression? Also, if I can discuss risperidone or Risperdal and its use for autistic meltdowns. So, Concerta, it's kind of a yes and no in terms of increasing aggression. So sometimes it's a little bit of a chicken or the egg thing. Because in ADHD, sometimes with the hyperactivity, sometimes kids can get like a little bit more aggressive. So sometimes like agitated. So sometimes that can be a symptoms of it. But sometimes I would say if you go overboard with your stimulant medications, sometimes that can worsen those sorts of symptoms. So kind of a bit of both, which is one of the reasons why typically we want to start out like, so for Concerta specifically, usually you'd start out at like either 18 or maybe 27 milligrams, sometimes maybe 36. It kind of depends how like old the child is, also to some degree, like how like big they are in terms of just like body mass as well. But yeah, usually it'd be like an 18, 27 or 36. And you can go like up to like 72 milligrams on Concerta. So like typically we want to like start out low and then work our way up, and hopefully not overshoot. So sometimes it can contribute to that, but sometimes it can help treat that. In terms of risperidone or other medications in terms of treating autism or some of the symptoms of autism, unfortunately, there's not any sort of thing that's like a disease-modifying medication for autism, at least not yet. And I mean, hopefully someday we get there for sure. So sometimes in an autism, you can definitely get like some agitation, aggression, the sorts of things that can happen. So sometimes Risperdal or other second-gen antipsychotics are used to help treat some of those symptoms. So it is targeted towards the symptom, specifically of aggression. One other medication that is sometimes used for that, that's a little bit outside of the second-gen antipsychotics, would be Depakote or valproic acid or divalproex, whatever you want to call it. It's got a few different names. Sometimes that's used for aggression as well. So it is something that is tried. Sometimes you can have some success with it. It's probably not going to completely get rid of symptoms, but can sometimes alleviate them or make them less severe or less frequent. Risperidone specifically is something that has like a lot of information in pediatric patients. So it is something that has been used for quite a long period of time in pediatric patients. So it has a good amount of data for its like safety, at the very least, in terms of use in pediatric patients. Other stuff would be like Seroquel, would also sometimes be used for a similar thing. So again, it's hard to say because it's not like there's nothing that's really specifically like FDA approved for treatment of like outbursts in autism. They are things that are sometimes used, because we knew it was safe. So we thought maybe, and like sometimes it can decrease aggression and stuff like bipolar disorder, especially if someone's in a manic episode. So there's like some rationale as to why it was tried. And there is some like data to support it. There's some data suggesting it's not necessarily the best. I guess I could say it's maybe worth a shot. And then just kind of monitoring to make sure there's no like significant side effects that are occurring. Because you never want to, keep using a medication where the side effects are, outweighing any sort of benefit that you might be having. So yeah, it is a thing that, we do use that like on the inpatient side as well. So it is something that is not uncommon to use, but also not really expecting, huge dramatic changes, I would say.
Thank you very much.
Yeah, no problem.
I wanted to say thank you again, Dr. Dispensa, and thank you all for joining us today. I hope that you'll come back and we get to do this again.
Oh yeah, yeah. No, happy to do it.
It's awesome. Thank you for all that you do for the community.
No,
Appreciate
no
you.
problem. Thanks for having me. And yeah, we'll definitely be doing this again. So
All right.
you guys
Good night,
have a good
everybody.
one. Yeah, thanks for really good questions from everyone. So yeah.
Bye.
All right, bye.